Hello everyone, my name is Efrem Bancha. Today we are going to talk about bariatric surgery for ABSITE and ABS written exam 2027. This all gonna be flashcard. First, I will display the question and then followed by answer on the coming slides. So our first question is, what are indications for bariatric surgery? This is directly straight forward from NIH Consensus 1991. Per this consensus, the indication for bariatric surgery is primarily based on BMI. So BMI greater or equal to 40, which is severe obesity or morbid obesity, is clear indication for bariatric surgery, or BMI greater or equal to 35 plus one or more serious obesity related comorbidities such as type 2 diabetes, hypertension, coronary vascular disease, cardiovascular disease, obstructive sleep apnea, severe hyperlipidemia. Those are indications for bariatric surgery. This consensus guideline is actually very old. There is recent update on indication for bariatric surgery in 2022. We will discuss that later on this session. But ABSITE still tests the old guideline. Insurance also, because of insurance also pay based on this old guideline. But this guideline is not evidence-based, it's opinion-based. There were 14 physicians involved in formalizing this indication for bariatric surgery back in 1991. Two of them are only surgeons, the rest were non-surgeon physicians, and they came up with this consensus. So, but still, we are being tested on this. I believe the guideline, the exam, gonna catch up, in a year or two. I'm not sure, but you guys have to make sure that the new guideline. There is a new guideline out there for indication of bariatric surgery. So this is the old consensus guideline. So the other question you can easily answer on ABSITE again is from NIH 1991. What are the major contraindications to bariatric surgery? Major contraindications are the follows: active substance abuse, uncontrolled major psychiatric disorder, end stage organ disease. This is controversial. Some people do bariatric surgery during transplant or after transplant. And the other contraindications are inability to participate in post-operative care or medical condition which affects survival after bariatric surgery. So there is a recent update on indication for bariatric surgery from 2022 American Society for Metabolic and Bariatric Surgery and International Federation for Surgery of Obesity and Metabolic Disorders. Per this guideline, we came down on BMI. BMI used to be, the cutoff used to be 40 without comorbidities. Per this guideline, BMI greater or equal to 35, surgery is indicated regardless of the comorbidities. And BMI 30 to 34.9, we should consider surgery if metabolic disease present. And thresholds is lower for Asian population. And for example, 27.5 with comorbidity is indication for bariatric surgery in those population. And this make sense given that obesity is progressive disease. It's better to treat early than later on. So what percentage of patients have resolution of pseudotumor cerebri after bariatric surgery? This is 90%. Actually, this is the highest comorbidity improvement after bariatric surgery. Why does bariatric surgery improve type 2 diabetes before significant weight loss? This is because of the enzyme and hormonal effect. They're going to be, especially with Roux-en-Y gastric bypass, they're going to be increased GLP mediated insulin secretion from LDL in ileum and the colon, which also that stimulates increased beta cell function, increase insulin sensitivity. Uh, those are main reason that patients see the improvement in metabolic parameters, glucose, hemoglobin, A1C, prior to losing significant amount of weight. So now we are going to talk about very relevant, important hormones and enzymes in bariatric population. So the first one is, what is peptide YY and its role in bariatric surgery? So this is a gut hormone from distal ileum and the colon, released after meals, and slows gastric emptying like GLP-1, and it increases after Roux gastric bypass. So the difference between sleep and the Roux gastric bypass, in Roux gastric bypass, distal the duodenum and the part of stomach and part of jejunum are excluded. That makes the nutrient to arrive to distal ileum sooner. That stimulates secretion of like GLP-1 and the peptide YY from LL cells. What is ghrelin and its role in bariatric surgery? This is specifically with sleeve gastrectomy. This ghrelin is secreted from gastric fundus, and the gastric fundus is removed in sleeve gastrectomy. That shows result in a sleeve patient. And the effect of ghrelin is it's appetite stimulating hormone. If we remove appetite stimulating hormone, the patient gonna have decreased hunger and food intake. So it's both restrictive, and it has also the hormonal change, which contribute to decreased weight loss. So the next enzyme is GLP-1 and its role in bariatric surgery. GLP-1 is incretin hormone. It's secreted from L cell like peptide YY, and it increases insulin secretion, and it also suppresses glucagon, and it increases satiety by sending signals to hypothalamus, and it delays gastric emptying. Its amount significantly increase after Roux gastric bypass because of the duodenal exclusion. So our next question is, why does Roux gastric bypass have stronger metabolic effect than sleeve gastrectomy? This is we indirectly talked about it. There is rapid nutrient delivery to distal ileum because of excluded duodenum, and that increased GLP-1 and the peptide YY. So that is the reason. So our next question is, in obese patient with type 2 diabetes, how does bariatric surgery compare with intensive medical therapy for long-term glycemic control? So there is a paper, a trial called Stampede trial. This is this paper clinical trial. The intensive medical therapy plus bariatric surgery is superior to intensive medical therapy alone in achieving adequate glycemic control. I think this potentially can be tested. So what are the key components of Roux gastric bypass anatomy? This is very important for residents to, especially the junior level resident, to understand this. So what do we do in Roux gastric bypass? We create small pouch of stomach, 15 to 30 ml of ml pouch. And then, the jejunum makes Roux lymph, and then there is below pancreatic lymph, and then we connect jejunum to jejunum. That's called jejunostomy. So in this procedure, distal stomach, duodenum, and the proximal jejunum are excluded. So, what are the possible Roux-en limb route in laparoscopic Roux-en gastric bypass? This is very relevant to understand because understanding this is very important to understand internal hernias. So there are four ways: anterior to stomach, posterior to stomach, posterior to colon, anterior to colon. So anticolic, antigastric, anticolic, retrogastric, retrocolic, antigastric, and retrocolic, retrogastric. So what does anticolic Roux-limb configuration means in Roux-en gastric bypass? So anticolic means anterior to colon, transverse colon. It's very important because there is no creation of mesocolic defect in anterior anticolic route. So that decreases the risk of having transverse mesocolon hernia compared to retrocolic. So you guys can see on the image, the anticolic one passes anterior to the colon, retrocolic passes posterior to colon. The next question is the same. Retrocolic, Roux-en limb passes through the transverse mesocolon, requires creation of a mesocolic defect, which increases the risk of having transverse mesocolon internal hernias. So the same is also true for retrogastric Roux-en limb routing, which also increases the risk of having internal hernias, retrogastric. So what are the major types of internal hernias after Roux-en gastric bypass? There are three major types. The first one is Peterson hernia, jejunostomy or introstomy mesenteric defect hernia, and then transverse mesocolon defect hernia. So I used to confuse Peterson hernia with transverse mesocolon defect hernia, but they are two different entities. I think our first question is, what is a Peterson hernia in Roux-en gastric bypass? So in a Peterson hernia, herniations between Roux-en limb mesentery, and there is, so the thing, two things, between the transverse mesocolon and then the Roux limb mesentery of which is jejunum. So it occurs both in anticolic and the retrocolic configuration. But in contrary to transverse mesocolon defect hernia, it occurs only with retrocolic configuration. It doesn't occur with anticolic configuration. So make sure you guys understand, and I put really nice image there as well. So which internal hernia is specific to retrocolic Roux-en gastric bypass? Is it Peterson hernia? No, Peterson hernia occurs in both anticolic and the retrocolic approach because it occurs between the mesentery of Roux-en limb and the transverse mesocolon. So the answer for this question is which one specific to retrocolic is transverse mesocolon defect hernia caused by passage of Roux-en limb through mesocolon. And you guys can see this image. This is very beautiful image right here. Why do internal hernia occur more commonly after significant post-operative weight loss? One, during creating anastomosis and the routing, we create mesenteric defect, and after the patient lose weight, then that defect gonna get bigger, and that contribute for development of internal hernias. Which bariatric procedure is preferred for obese patients with pre-existing GERD? This is also commonly tested question. So Roux-en gastric bypass is better, preferred, and the sleeve gastrectomy might worse GERD. So the way they give this scenario on test is like a 35 years old female patient with body mass index of like 40, here to get consultation for bariatric surgery, and then which procedure you recommend, and then on top of that they add the patient has like refractory GERD on PPI, or patient frequently uses PPI for reflex disease, which kind of bariatric surgery do you recommend? And then A, room wide gastric bypass, B, sleeve gastrectomy, C, then laparoscopic banding, and then of course you guys have to get this wide gastric bypass is recommended. So, which typical roux limb length? What is the typical roux limb length for laparoscopic roux gastric bypass? It is 75. It depends on BMI, but the most acceptable range is 75 to 100 to 150 are the commonly used length. So, what is the key concern with internal hernia after roux gastric bypass and how it should be managed? This is also very important concept to understand for exam as well as a real clinical setting. So the patient with internal hernia usually present with classic sign and symptom of bowel obstruction, and you order CT scan, and CT scan can be normal in 30% of cases. So on exam, if you they give you a patient who had roux gastric bypass like 2 years ago, now presented with nausea, vomiting, and CT scan was done, and it's CT scan of the abdominal pelvis with oral and PO contrast is done, and it doesn't show any small bowel obstruction. Even say they like that, and what are you going to do next? And you must take that patient to operating room for immediate laparoscopic exploration, even if the CT scan is negative. Very, very important concept to understand. So, what is marginal ulcer after roux gastric bypass? Its presentation and the treatment. Marginal ulcer is like kind of any ulcer, but happens after roux gastric bypass, and the presentation is like any ulcer. The patient is going to have epigastric pain, nausea, vomiting. If it's associated with, especially with strictures, the patient is going to have dysphagia and GI bleeding. And in long-standing patient might have anemia. And then risk factors. What are risk factors for marginal ulcer after roux gastric bypass? Those are smoking, NSAID, and actually the patient need eradication of H. pylori before we do roux gastric bypass. And a larger pouch also increases the risk of having marginal ulcer, and it usually happens weeks and months after surgery, and a mode of diagnosis say forward by using upper GI endoscopy. And the treatment is medical. Most of the time we have to eliminate risk factor, put the patient on high dose PPI, but if the patient has developed complication like bleeding, perforation, stricture, on those cases we patient going to require endoscopic or surgical revision. So next slide, anastomotic stricture after roux gastric bypass presentation and the treatment. So stricture is like mechanical, so it causes progressive dysphagia first to a solute, then progress to the liquid. It typically occur 4 to 6 week post-op. And this is very relevant question to understand for ABSITE. So what is treatment for stricture? Always balloon dilation, the first line treatment, not surgery. And even if the patient fails to respond for first endoscopic balloon dilation, the repeat dilation is often required before we take the patient for surgical revision. So surgery is only indicated for refractory cases. All right. This is very, very important question to understand in real life, also in ABSITE. So persistent tachycardia over 120 after roux gastric bypass should be considered dash until proven otherwise. It is anastomotic leak. Top differential diagnosis is anastomotic leak, followed by pulmonary embolism. But patient in pulmonary, this is taking proper history and doing physical exam and doing labs are very relevant. What makes PE? If this PE, the patient gonna desat, oxygen saturation gonna drop, the patient gonna have tachycardia, and then in that case, if you have like mixed thinking of it can be leak or it can be PE, then when you order CT abdominal pelvis with PO and IV contrast, you can also send PE CT protocol to rule out pulmonary embolism. The other common cause of tachycardia after any surgery is pain. So make sure that the patient's pain is well controlled. Those are like the way you think when you see persistent tachycardia on those post-operative patients after bariatric surgery. So our answer is anastomotic leak. Mention initial management of a leak after. So there is hole in hollow organ. So it's true in every case of perforation. That's the first thing the patient in this bowel rest and NAPO, and you have to start aggressive fluid resuscitation. We got to start the patient on broad antibiotics, gram positive, gram negative, anaerobes, and in immunocompromised and really sick patient, we have to also add antifungals. And then if the patient is stable enough, we send CT abdominal pelvis with IV and oral contrast. If the patient is not stable, and if the patient is hypotensive, then the patient has to be like, we have to take the patient to operating room for XLAP and then OR washout. So here, this is true in any cases on ABSITE. Whenever you see any patient present with surgical patient present with hemodynamically unstable, and you think there is a surgical pathology going on intra-abdominal, then you take to operating room for XLAP than waiting for imaging. Mention options for leak management options for leak after laparoscopic Wu-Y gastric bypass, indication for endoscopic therapy. For endoscopic therapy, the patient must be stable first. The patient should be stable, small contained leak, or in cases nowadays, endoscopic vacuum therapy are increasingly used for chronic and complex leak. And then the patient should have controlled sepsis in rare cases, not commonly, but we don't use in this case. But like sometimes, from my reading, controlled sepsis is advocate drainage. In that case, you might use endoscopic approach. Endoscopic treatment option for leak after Wu-Y gastric bypass there are many of them. They usually, so as a resident, what we do is we call GI colleagues, and they might do covered self expanding stent. And now usage of endoscopic vacuum therapy is increasing. And then endoscopic suturing, then we might do internal drainage with double pigtail stents. Oh, those are all options for endoscopic intervention of the leg. Management option for laparoscopic Wu-Y gastric bypass, indication for surgical washout and exploration. This is we already discussed. Hemodynamic instability, septic shock, diffuse peritonitis, early large amount of leak, failure of non-operative management, uncontrolled contamination. In those cases, the patient should be taken to OR for operative washout and exploration. So management option for leak after laparoscopic Wu-Y gastric bypass, indication for percutaneous IR drainage. IR is indicated only if the leak is contained in the small. So no diffuse peritonitis, accessible location on imaging, localized fluid or collection or abscess, contained one, and the patient must be hemodynamically stable enough, then you have to call IR for percutaneous tube placement. Two most common micronutrient deficiencies after Roux gastric bypass. Very important to understand. Those are iron and B12. Iron, because iron is absorbed from a duodenal and proximal duodenum, which is bypassed in Roux gastric bypass. That is the reason. And the reason for vitamin B12 deficiency is there is decreased gastric acid and intrinsic factor exposure, which result in decreased B12 absorption. Kind of here, you guys have to understand. Even if you want to, the patient is in POB12, still it's less likely going to be absorbed. So you have to think about different route of administration, like spray or like injection is better than oral administration. But regarding iron, gluconate form is the best to be absorbed in the patient after Roux gastric bypass. So other important micronutrient deficiencies after Roux gastric bypass are folate. Folate causes microcytic anemia. Thiamine is very important. I think I have more slides coming after this regarding thiamine. Is one thing you have to understand is we don't store thiamine for a long time. The patient, because of vomiting, decreased appetite, easily can deplete their storage from liver. So the patient are at risk of Wernicke's encephalopathy and the neuropathy, which very. So Wernicke's encephalopathy, mnemonic is CAN, C for confusion, A for ataxia, and N for neuropathy. So please, Wernicke's encephalopathy, remember that. And then calcium and the vitamin D, because of they are usually absorbed from duodenum, and there is also no acid. Because of that, the patient usually might develop calcium and vitamin D deficiency. So that can cause secondary hyperparathyroidism, bone loss, osteopenia. Other is copper, and copper deficiency can cause anemia, myelopathy, and the neuropathy. And the other is other deficiency might occur is fat soluble vitamins A, D, E, K. All right, so this is very relevant, important concept to understand for ABSITE. Biliary drainage option in acute cholangitis after Roux gastric bypass. So the reason I brought this flashcard is, the anatomy is altered after Roux gastric bypass. So you can't go directly from stomach to duodenum in Roux gastric bypass. Duodenum is bypassed, proximal duodenum is bypassed. So in that case, you have to come up with different route to drain. If you want to decompress gallbladders, you have to come with different way. So what are possible ways? One, EDG, EUS directed transgastric ERCP. So you have to do ultrasound to the stomach, that is EUS, endoscopic ultrasound, and then you go through stomach to the ampulla of Vater. That is one way, and the other way is other way to do decompress biliary tract is laparoscopy assisted ERCP. So this is, you have to, the way you have to do is you have to go to the stomach, the bigger stomach, not the smaller pouch. You have to go through the bigger excised stomach, bypass the stomach, and go through that through laparoscopy and do ERCP. And the other is like any case of, like, if you want to go down to small bowel, you have to use balloon-assisted introscopy. That is double balloon introscopy or single balloon introscopy, also possible option, but success rate is lower and this takes longer procedure time. And the other way is if the patient is unstable and they're really sick, then in that case is you have to call your IR colleague for percutaneous transhepatic biliary drainage. That is indicated for unstable patient and or like endoscopic approach fails. So ABSITE high yield note here is Wu-Wei gastric bypass standard. In Wu-Wei gastric bypass standard ERCP is not possible. If unstable, then you have to call IR for percutaneous transhepatic biliary drainage for immediate decompression. But if the patient is stable enough, then one of those three options can be used to drain biliary tract. What are typical outcome of laparoscopic Wu-Wei gastric bypass in terms of weight loss and the diabetes remission? They sometimes I have seen this, tested on standardized exams. So excess weight loss is 60 to 75%. And please do not confuse this excess weight loss with total body weight loss. That's completely different. Total body weight loss may be 20-30%. It's not 60 to 75%. So excessive weight loss, EWL, is 60 to 75%, and diabetes remission is 50 to 70%, a little bit higher than sleeve gastrectomy. So the next question is, what are typical outcomes of sleeve gastrectomy in terms of weight loss and diabetes remission? Excess weight loss in sleeve gastrectomy is 50 to 70%, a little bit lower, and diabetes remission is 40 to 60%, a little bit. The lower cut is like lower. Instead of for excess weight loss, instead of 60, it's 50, and for diabetes remission is like about 40% instead of 50 with Wu-Wei gastric bypass. All right. How does laparoscopic sleeve gastrectomy induce weight loss? We talked about restriction because of the narrow sleeve decreases intake, and then fundus resection decreases ghrelin, which decreases ABSITE. Common late complication of laparoscopic sleeve gastrectomy are, as we talked about this, GERD. If the patient has GERD or reflex disease, at the first place, do not recommend sleeve gastrectomy as a way of bariatric surgery for those population. The other long-term complications are sleeve stricture or stenosis, weight regain, nutritional deficiencies, hiatal hernia, chronic staple line leak, or fistula. Okay. Staple line stricture after laparoscopic sleeve gastrectomy presentation and treatment is same with Wu-Wei gastric bypass. Presentation is progressive dysphagia, postparental vomiting. So treatment is exactly the same like stricture status post Wu-Wei gastric bypass treatment. First line endoscopic balloon dilation, often repeat dilation is required. In case of refractory, then the patient might need surgical revision, such as maybe conversion to Wu-Wei gastric bypass. So only in refractory cases, the patient needs conversion or surgical revision. Staple line leak after Wu-Wei, not Wu-Wei, I'm sorry. Staple line leak after sleeve gastrectomy timing and the classification. This can be classified early. If the leak happens in the first 3 days, that means the problem is technical failure. Intermediate, which is 4 to 7 days, and if it happens after a week, it is usually chronic due to ischemia and chronic pressure. And you guys have to know this. This can be easily tested on ABSITE. Most common site for leak after sleeve gastrectomy is proximal staple line near GE junction. Near GE junction. This can be tested. All right. Manage presentation of leak. It's like any leak. It's tachycardia. Please, tachycardia, fever. If the patient like stay longer enough, then the patient gonna have sepsis, hemodynamic stability. In white cell, you see elevated leukocytosis with white left shift. So treatment for leak after sleeve gastrectomy is same like Roux gastric bypass, NPO, IV fluid. The initial general treatment is same. NPO, IV fluid, resuscitation, broad spectrum antibiotics, CT with oral or and IV contrast, and then if the patient is stable and if the leak is contained, then IR is preferred. And if the patient is very sick, then anytime sick patient go to where ICU. So definitive management option for staple line leak after laparoscopic sleeve gastrectomy are endoscopic, percutaneous drainage, IR guided, surgical washout, and the drainage if unstable. And then during that procedure, you also have to think about nutritional support. So you have to do J-tube for nutritional support. And then in refractory chronic leak, patient might need conversion to wide gastric bypass or in very rare case gastrectomy. All right. So this is this is not commonly done now, and this is duodenal switch with biliopancreatic diversion anatomy. It's very important to understand. Here, you know, the patient gonna have sleeve gastrectomy. We're gonna create small pouch stomach, and then we divide duodenum just distal to pylorus. That is different from Roux gastric bypass. We divide after ligament, a few centimeters down from ligament of trites. Here we divide duodenum proximally just distal to pylorus, and we take this distal this duodenum proximal duodenum to the ileum, and so we bypass the majority of the small bowel, and then the rest of alimentary limb alimentary limb anastomosis distal limb, we talked this already, and the below pancreatic limb, which is very long in this case, and then we create common channel. So this common channel is usually 100 and 150. This actually define how much weight the patient gonna lose. So the problem of this procedure is, since the majority of proximal duodenum, jejunum, ileum are bypassed, the patient gonna have significant weight loss, and the patient gonna have like fat malabsorption that will contribute to severe malabsorption of protein and fat soluble vitamins, chronic diarrhea, steatorrhea, and this procedure actually has the highest nutritional risk after bariatric procedure. All right. So our next question is: 42 years old gastric band patient develops new reflex, persistent vomiting, nighttime regurgitation, and progressive food intolerance. What is next step? What do you guys think? So any patient after lap band comes with persistent vomiting, sign of dysphagia, the first thing we have to do is immediate band deflation. And then we can, or if the patient is stable, in that stable patient, we order upper GI studies, contrast study, to see the position of the band, or plus or minus endoscopy if it is indicated. So and then definitive management is actually based on, obviously based on the finding we get from imaging. All right. What is management for kinking of gastric band tubing at its connection with the subcutaneous port on KUB? So you do KUB, the band is in the correct place, but there is a kinking. You clearly see there is a kinking at the kinking of the gastric band tubing at its connection with subcutaneous port right there. So in this case, you have to do local exploration with lidocaine. So kinked tubing at at port site, inability to inject or withdraw saline during band refills. The treatment is exploration of the port and the tubing under local anesthesia. So recurrent port site infection plus weight regain plus vague epigastric pain in gastric band patient. What is his concern? What? All right. This is classic presentation of band erosion. Eroded band allows bacteria tracking along the tubing and causes recurrent port site infection, also causes loss of restriction, and that's the reason for weight regain. And the patient usually have non-specific epigastric pain. And the treatment, the mode of diagnosis is endoscopy, and the treatment is removal of the lap band. All right. Dysphagia, regurgitation, chronic cough after banding, and upper GI series shows dilated esophagus, this mega esophagus, that because of the too tight. Diagnosis is esophageal dilation from chronic obstruction, and deflate the band, and often this usually requires permanent removal of the band. All right, what is normal phi angle for properly positioned laparoscopic adjustable gastric band, and what does phi angle of 90 indicates? This is very commonly tested question on standardized exam. Phi angle is, I put image here. Phi angles are usually normally should be I think I should have included this here. Oh, sorry, hold on. All right. So usually it's max 58, if I'm not mistaken, but it never be 90 degree. If you see phi angle here on second image, seeing the band is creates like a 90 angle with vertebrae. So the vertical axis is the vertebrae, and then you draw imaginary line over the band and see the angle. And if that angle is 90 degree, that clearly tells anterior gastric band slippage. So on the first image, if you see the vertical axis over the vertebrae and then the angle over the band, and the angle is like less than 45 degree or max 45 degree. So in that case, this is normally positioned band. So please understand this. They might give you this image. So the phi angle 90, or the right angle, that is not normal. That is anterior slippage of gastric band. All right, in dehydrated post-bariatric patient with vomiting, what is correct sequence of emergency treatment? The main reason that I brought this flashcard here is thiamine. Please, thiamine. So thiamine, always, like alcoholic patient, comes with vomiting, you first give thiamine prior to giving any glucose-containing fluid, because if you give glucose prior to thiamine, the patient is going to have worsening of Wernicke's encephalopathy, or the patient might have permanent neurologic damage. So thiamine, IV fluid, and then a glucose-containing fluid if needed. Avoid glucose before thiamine, risk of Wernicke. What are early clinical signs of thiamine deficiency after Roux gastric bypass? So we are now going to talk about specific vitamins, and this is easy question you can answer on ABSITE. So thiamine, this I think this time we have heard this millions time. Confusion, thiamine deficiency causes Wernicke's, encephalopathy, mnemonics of Kahn, confusion, ataxia, and then and the nystagmus, and then the patient have ophthalmoplegia. And the confusion and the mild altered mental status can be seen, then needs emergent thiamine IV prior to dextrose administration. Please memorize that. What vitamin deficiency after bariatric surgery causes night blindness? Night blindness caused by vitamin A. Vitamin A deficiency, please memorize that. Vitamin D deficiency after bariatric surgery. Presentation: secondary hyperparathyroidism, bone pain, osteomalacia, increased risk for bone fracture. So which vitamin deficiency after bariatric surgery cause neuropathy and ataxia? I think this is B12. Oh, vitamin E, sorry. Neuropathy with ataxia also that mimics vitamin B12, but you guys have to remember, especially if you see hemolytic anemia, ataxia, and peripheral neuropathy, and you don't see B12, this is other vitamin E can present in that way as well. What vitamin A deficiency after bariatric surgery leads to coagulopathy and easy persistence? Vitamin K, prolonged PT, INR, easy bruising, mucosal bleeding due to fat malabsorption, obviously. What causes vitamin B deficiency after bariatric surgery? You guys, we talked about this. All right. Lack of interest, loss of parietal cell, and presentation B12 is neuropathy. And on vitamin A, we talked about hemolytic anemia. Here, vitamin B12, the patient gonna have microcytic anemia, but it's rare. The patient, even if they have vitamin B12 deficiency, they rarely actually develop microcytic anemia in bariatric population. It's rare. Folate, B9 deficiency after bariatric surgery. Folate deficiency causes what? Also microcytic anemia. I jumped that. What trace element deficiency after bariatric surgery causes hypogonadism, poor wound healing, and hair loss? You guys have to remember this. Zinc. So the way I remember zinc is a lot of my bodybuilder or guys go to gym. They like zinc because they think that it increases the endogenous testosterone production. So it's related with gonadism. So lack of zinc can cause hypogonadism and alopecia. Lack of poor wound healing, and then altered test. So zinc causes hypogonadism, so alopecia, poor wound healing. So that's just memorize. Say it repeatedly until you guys memorize it. What deficiency after bariatric surgery cause peripheral neuropathy that mimic B12 deficiency, but with normal B12 level? Let me drink my water. Copper deficiencies. So copper deficiency also mimic B12, get disturbance neuropathy, anemia, and usually confused B12 deficiency. So read the question. If you don't see B12, don't say what the hell, where is the answer? So think about copper. All right. What deficiency cause cardiomyopathy and muscle weakness after bariatric? This should be selenium. Yeah, selenium deficiency causes cardiomyopathy, muscle weakness, and immune dysfunction. What deficiency after bariatric surgery present with weak nails, hair thinning, anemia, iron deficiency? Bone pain, tetany, muscle cramp, calcium. What mineral deficiency after bariatric surgery can worsen neuropathy and anemia? Magnesium. So if the hypocalcemia is refractory, this is commonly thing that we did in the real life. So you have to check magnesium level. I love magnesium supplement. Which deficiency causes glossitis, chelosis, and abnormal skin change after? This is riboflavin B12 deficiency, glossitis, angular cheilitis, dermatitis. This is very easy concept, but often tested and this potentially can be tested. So please, what deficiency after bariatric surgery leads to dermatitis? Three famous Ds: dermatitis, diarrhea, dementia, pellagra, niacin deficiency, or B3 deficiency. What deficiency after bariatric surgery? Microcytic anemia and impaired neurotransmitter. This is pyridoxine. Let me see. Yes, pyridoxine B6 deficiency, microcytic anemia, neuropathy, seizure in severe cases. Oh, this is also real life case. After foregut surgery, Roux gastric bypass or sleeve, the patient has nausea, bloating, and early satiety. What test needed before consider revision procedure? You must rule out damage to vagus nerve, which can causes gastroparesis. So nuclear medicine gastric imaging test or study, please. All right, this is our last flashcard. How are gallstones managed after bariatric surgery and its prophylactic and when is prophylactic cholecystectomy recommended? In symptomatic cholelithiasis, the patient should have laparoscopic cholecystectomy during time of Roux gastric bypass. Or asymptomatic, you don't have to do prophylactic cholecystectomy, but administration of ursodeoxycholic acid for 6 months reduces gallstone formation after bariatric surgery. And that is the end of high yield flashcards for bariatric surgery for ABSITE.